You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
So good morning, everybody. This is Conferences Online in Allergy. We're on Monday, September 12th. And for our second presentation today, we have Eyan Grunebaum, who is a clinician scientist and an allergist and immunologist. And he's at the Hospital for Sick Children in Toronto, Canada. We appreciate you coming to us from a far distance. His clinical and research focus is on the understanding, the diagnosis, and the management of patients with inborn errors of immunity, including the use of bone marrow transplantations and gene therapy for severe combined immunodeficiency, which is going to be the topic of his talk today. Thank you, Dr. Grunebaum, for being here.
Thank you for the kind introduction. Yes, today I'm going to talk about severe combined immunodeficiency, or SCID for short, past, present, and future. I'll start by saying that I have no conflicts of interest to declare. I have three main objectives to describe the classical, mostly historical features of severe combined immunodeficiency, then go over some of the impact of what newborn screening for severe combined immunodeficiency, how that has changed our practice, and I'll end with what I think is the most interesting part, where the future lies in the management of severe combined immunodeficiency. I'll start with a patient that was referred to us back in 2017 and 2007. I'm describing his presentation, although I must say that this has become now the expectation. Nevertheless, you might still encounter such patients in North America, and certainly this is possible in other parts of the world. So depending on where you practice, you might see these patients. This patient was sent to us when he was 8 months of age for recurrent otitis, an episode of X-ray proven pneumonia, intermittent diarrhea, and he was failing to thrive. He was from a non-consanguineous Polish family, and he had a maternal uncle that died in infancy in Poland from what they thought was infections, whatever that meant in Poland 30, 40 years ago. Physical examination revealed that he was cachectic and dyspneic. He had oral thrush, and impressively, he had no lymph nodes or tonsils. He did not have any skin rash or hepatosplenomegaly to suggest something called Omen syndrome. And if someone is interested, I can expand on Omen syndrome later in the question period. But for the sake of our discussion, there are no other significant physical findings. Chest X-ray showed bilateral basilar infiltrates, and in contrast to the normal thymus that you can see here with this arrow, our child, did not have any thymic shadow. This was later confirmed when ultrasound of his chest, which is really the preferred modality to assess the presence and size of the thymus. And the chest X-ray also showed ground glass opacities and septal wall thickening compatible with pneumonia. His laboratory features demonstrated normal neutrophils and platelets, but he did have profound lymphopenia. IgG was low, and IgA and IgM were undetectable. And although these are values that might be acceptable at this age because of the physiological nadir, where the maternal IgG that causes the placenta has been degraded, nevertheless, because he had so many infections so far, I would have actually expected to see some IgG, IgA, and IgM. So this was concerning. Another clue to the diagnosis was the fact that he had PJP pneumonia identified in his bronchoalveolar lavage. He also had CMV positive in his blood, and these were quite significant and alarming for the possibility that this kid might have might be suffering from an immune deficiency, although I still was not clear whether this was a primary or secondary immune deficiency. Speaking about secondary immune deficiency, whenever you're asked to consider a primary immune deficiency, always think that this might be a secondary cause. There might be a secondary cause. Secondary immune defects are much more common than primary immune deficiency. Whether it's HIV or EBV or TB or medications that either the mom or the newborn receive, they may all be reason for a secondary immune deficiency. So always think about secondary immune deficiency. But in our patient, there was none that we could identify, and we continued on to look at the lymphocyte subtypes. This is done by flow cytometry, and that demonstrated practically absence of T cells or natural killer cells, while the B cell numbers were normal. He also had no baby naive T cells, which are characterized by the expression of CD45RA on their cell surface, and the few T cells that he did have in his blood did not respond to stimulation that we did in vitro. All of this demonstrated that he had a T minus, absence of T cells, B plus, presence of B cells, and NK minus, absence of NK cell, severe combined immune deficiency. I want to spend a minute on the designation of the plus and minus nomenclature that I mentioned, because it does provide a preliminary clue to the genetic etiology of the severe combined immune deficiency. For example, absence of T cells with normal B cells and NK cells, which we would designate as T minus, B plus, NK plus, is characteristic of the George 22q11 deficiency, as well as CD3 delta deficiency, IL-7 receptor alpha deficiency, and so on. In contrast, T minus, B plus, NK minus, such as what our patient had, is almost pathognomonic to IL-2 receptor gamma deficiency or JAK3 deficiency. And I won't go further into this nomenclature because there's a growing list into each one of them, and there's recent publications that can give you a better indication, a longer list for each one of these. But it is important to look at the T cells, B cells, and NK cells. Although I should also caution you that's always it's not always as accurate as genetic testing. So genetic testing should eventually be done. But this does give you a good clue to what you should be looking for. So this is part of the list that I mentioned. Again, I won't spend time on lists because it's impossible to remember them. It's important to know that you should be looking at them once you do find a patient with severe combined immune deficiency and you've completed his immunophenotyping. So in our patient, the defect was in the gamma chain of the IL-2 receptor gamma. It's also called, known as the gamma common chain. The name comes from the fact that the same name is required both for the IL-2, and hopefully you can see my pointer, the IL-2 receptor, the IL-7 receptor, and the IL-15 receptor. And these are important for T cell development and NK cell development. They're not important for B cells, which is why these patients are characterized as T minus, B plus, NK minus. The IL-2 receptor gamma, the gamma common chain, is a gene that is encoded on the X chromosome. So males are affected while females are carriers. This is why this is also called the X-linked SCID. And in North America, at least, it's considered the most common cause of severe combined immunodeficiency. Although in some states and some countries where consanguinity and founder effects are prevalent, autosomal recessive SCID caused by RAG1 or RAG2 deficiency is much more common. Nevertheless, in North America, X-linked SCID is the most common cause of severe combined immunodeficiency and is the most likely cause of SCID that you will encounter. I cannot emphasize enough that how much SCID is a medical emergency. Probably the only time that I tell my trainees to actually call me in the middle of the night. This is critical because these patients can crash within hours, so they need supportive treatment as soon as possible. We need to look for and treat their infections. There are even places that routinely do bronchoalveolar lavage on such patients to look for pneumocystis jirovecii pneumonia. It's very important to prevent their infections by minimizing exposure to the team and family members. In the past, we used to place them in bubbles, diverse isolation bubbles, although this is not done, at least not routinely anymore in most places. We also start immunoglobulin replacement and PJP prophylaxis in these patients. Some places also start fungal and CMV prophylaxis, and there's a recent publication from 2021, the isolation infection screening and prophylaxis that are done in many centers across the US, so I won't go into the full description. I will emphasize that it's important to consider at least stopping breast milk at least until you confirm that there's no CMV that might be transferred in the breast milk. Many of these patients do need NG feeds, TPN, and so on. And so these are complicated patients to manage, and it really requires a team of experts to do that. But all of these are only supportive care. Eventually, what they need is a new immune system. So to do this while stabilizing the patient, it's really important to try and identify a potential bone marrow or stem cell donor that could be used as soon as possible for these patients. We often start HLA typing for the patients, for their parents and siblings as quickly as possible. And there have been times that we were able to identify and rush into a transplant within 1 or 2 weeks. So really, I cannot emphasize how urgently this needs to be done. In parallel, we also try to establish the etiology of the severe combined immunodeficiency, because in some conditions, we may not proceed to transplant, or we might even want to consider a different approach in terms of management. And I'll go into some of these later on, but this is to emphasize that it's really, really important to try and establish the etiology of the severe combined immunodeficiency. Going back to our patient, he was fortunate enough to have an HLA-matched sibling donor. So after controlling his infections, we did I proceed with an HLA-matched living unrelated donor, and it took about 3 months to control the infections and to identify the donor, and eventually we got to the transplant. Unfortunately, the patient did suffer from grade 3 graft-versus-host disease of the liver, the gut, and the skin, and it took us about 6 more months of immune suppression to finish until we got that under control. He's now 13 years later. He does have significant lung damage, possibly from the PJP, and he has hearing impairment due to the CMV. But he's doing well. He's has now normal immune constitution. He's not receiving any medications, and he's about to finish high school. So how did our patient do in comparison to other patients transplanted at the same time? This is a review from the New England Journal of Medicine from 2014 that looked at the outcome of patients with severe combined immune deficiency from the primary immune deficiency treatment consortium. And as you can see, when they looked at 240 patients with severe combined immune deficiencies, most of them did quite well after transplant with a 75% long-term survival, especially if they received matched sibling donor or mismatched related donor. The problem was that if patients had active infections, they did not do as well. And you can see it, especially here, that patients who had an active infection and did not go to transplant very early after birth had only about 50% survival. So these were very significant risk factors that were able to that were very important in determining outcome of patients. I'll jump on this one because I do want to move forward. We did this paper indicated that the outcome of severe combined immune deficiency really depends on early diagnosis and transplant prior to the development of infections. So how do we achieve that? How do we diagnose severe combined immune deficiency? Well, for that, I want to talk about the second patient. For this patient, I was called for in 2018. He was referred to us in 2018. Again, he was diagnosed with absence of T cells and NK cells and with B cells, except that in this case, the patient was flagged very early in life. I saw him when he was only 1 week of age, when he was actually free of infections. And this was thanks to the newborn screening program that was established here for severe combined immune deficiency. So in 2013, following many US states, Ontario introduced newborn screening for severe combined immune deficiency. And this is based on something called the TREC assay. And actually, since 2018, all newborns in the US are screened for this. So most likely, when you will see a patient with severe combined immune deficiency, this patient would have been picked up by newborn screening through this TREC assay. So what is the TREC assay? The TREC assay, the T cell receptor excision circle, is based on the fact that T cell receptors rearrange the VDJ gene segments that code for a specific T cell receptor. And when they do that, a small piece of DNA is excised from this by this approximation of the DNA. And you can see it in this cartoon, how this little piece is excised. It forms a circle that can be detected by PCR. That circle stays in the T cells that are released from the thymus and can be detected in the peripheral blood by PCR. This is if a drop of DNA, if a drop of blood is absorbed into the guthrie cards that are taken from every infant, this can be measured by punching out a small piece of this card, extracting the DNA and measuring the number of T cell receptor excision circles as an indirect measurement of the T cells that are in the blood. The absence of TREX is practically pathognomonic for severe combined immune deficiency, obviously assuming that the sample or assay were not compromised. There are some labs that report lower than normal TREC numbers, so not complete absence. And this does indicate that these tests may have some sensitivity and specificity issues, as well as false positive and false negative values. There are some finesse interpretations of these, but it is very important to consider that each one of these patients might have a profound T-cell immune deficiency. And so what we do is that every patient who has an abnormal result, we bring them in and we do analysis by flow cytometry of their lymphocyte subtypes. We also measure whether or not they have naive T cells in their blood. We have found that there are what I call false positive patients who very soon will normalize their TREC numbers. This is mostly due to prematurity and low birth weight, sometimes because of sepsis or loss. But I'm more concerned about the true false positive, those who have persistently low TRECs, which might be due to a true immune deficiency. So all patients who have abnormal TREC values need to be evaluated. You should also remember that, like any screening assay, there might be still some false negative, i.e. patients with severe combined immune deficiency that are missed. It's rare, but it does happen. And the paper that I quoted at the beginning of this publication, of my presentation, was missed in Michigan a couple of years ago. So it does happen. So you must continue to be vigilant for the possibility that patients might have severe combined immune deficiency, even if they have not been picked up by newborn screening. Today, most of the patients that you will see, as I mentioned, will be picked up by newborn screening. And this is another paper that looked at 100 patients with severe combined immune deficiency. As you can see, over the last couple of years, there have been a significant increase in those who are diagnosed by newborn screening and a reduction in those diagnosed by infections, although this still happens. What do we do with these new patients that are diagnosed with severe combined immune deficiencies? Well, they're clinically well, so we often don't admit them to the hospital anymore. We encourage isolation at home if possible, and we see them every week or two in the clinic until we identify the best donor. So now most of the patients are identified without infections, and with that, we have been able to significantly improve the outcome of transplants. And in most kids, you can expect a 90–95% survival if indeed they are picked up when they are infection-free. So going back to our patient, he had T-, B+, NK- SCID, and by now you should be able to quickly make the diagnosis that he had an IL-2 receptor gamma deficiency, which indeed we confirmed within 1 week. Unfortunately, he had no matched sibling donor, and we did find a matched unrelated donor. Still had some questions how to best prepare our patient for transplant. What we call conditioning, what kind of chemotherapy should we use? How can we best prevent graft versus host disease? There is although we match for 8 or 10 HLA antigens, there are still many major histocompatibility factors that we do not measure. So there is still a high probability of graft versus host disease. And should we proceed with allogeneic hematopoietic stem cell transplant, or should we even consider gene therapy? After discussions with the family, we did proceed with a matched unrelated transplant. We used reduced intensity, reduced toxicity conditioning, and we used prophylaxis with methotrexate and tacrolimus. The patient is now 4 years old. He received the transplant. He had no significant complications, and he's fully engrafted and he has normal immunity. Nevertheless, these questions, how to prepare the patients, how to prevent graft versus host disease, and whether to proceed gene therapy, have continued to haunt us for the last couple of years. And so I do want to talk about them because I do think these are things that will be done differently than what we did with this patient in 2018. So really the question is, how can we proceed and do things better than what we've done so far? Can we prevent the complications that might be associated with chemotherapy, with conditioning? Should we use maybe less chemotherapy? We already know that in patients that have some gene defects, we do need to, or we can get away with less conditioning. Although if we don't use conditioning at all, then patients, for example, with the IL-2 receptor gamma, such as what our patient had, 50% of them will require lifelong immunoglobulin replacement. But if we use full myeloablative conditioning, then we avoid the risk of immunoglobulin replacement, but there is a higher risk of late complications. So now we're looking into transplants. We're looking into a prospective study that will help determine the minimum amount of chemotherapy, such as busulfan, that is needed to establish the appropriate dose of conditioning. There's also a new interesting development where we can use antibodies that will target the hematopoietic stem cells in the bone marrow and completely avoid the need of chemotherapy. How do we prevent graft versus host disease? That has been in the past done by non-specific medications such as steroids, cyclosporin, tacrolimus, sirolimus, but these medications have many adverse effects. So one of the new thoughts is to remove the T cells and B cells that are responsible for graft versus host disease, such as by specifically targeting with antibodies there's T cells and B cells. And indeed, there are now several studies that are looking into the depletion of TCR alpha beta, the GvHD mediating cells, as well as the CD19 B cells that are responsible for graft versus host disease. Another strategy that is now being employed in many centers is to give a very low dose of cyclophosphamide 3 to 4 days after the transplant, and that eliminates the T cells from the donor graft. These cells that tend to proliferate 3 to 4 days after the transplant because that's when they are exposed to the recipient tissues. So we cache these T cells, the alloreactive T cells, at the time when they're proliferating, and they're very sensitive to this low-dose cyclophosphamide. So several strategies to try and eliminate the T cells, the donor T cells, from preventing graft versus host disease. Another very exciting option is gene therapy. Gene therapy for X-linked SCID has been something that people have been envisioning for many, many years. Actually, the earliest studies in gene therapy for X-linked SCID were already began in the early 2000s. They used a retrovirus, a gamma retrovirus, to deliver the normal gene into the patient's bone marrow cells, and then they infused the cells back into the patients. Unfortunately, they found out that 5 of the initial 20 patients developed leukemia and lymphoma. And that was because the gene that they delivered, the vector that they used, the retrovirus that they used to deliver the gene, tended to integrate and disrupt oncogenes. So 25% of the patients eventually developed malignancy. It took almost a decade to figure out how to do this in a correct manner. They developed a safer retrovirus, safer delivery method, and were able to avoid the leukemia. Nevertheless, they found out that the immune constitution was incomplete. Eventually, they found out that this was because they avoided the use of chemotherapy. And when they avoided the use of chemotherapy, they were unable to engraft T cells. So now they figured out they needed some amount of chemotherapy to allow engraftment of the corrected T cells, and that these corrected T cells would need to also interact with the corrected B cells. So it was not enough to correct just the B cells. They needed to engraft T cells. So now, how is it done? We take bone marrow or peripheral blood stem cells from the patients. We incubate them with the virus that has the gene of interest, and then we infuse them to the patients. After the patient receives some conditioning with either chemotherapy or radiotherapy, we usually use chemotherapy, a small dose of chemotherapy, and then these cells continue on to expand in the patient. This has become quite successful. There was a very recent publication that showed the safety and the efficacy of this approach. They gave a very low amount of busulfan to patients and were able to demonstrate very good immune reconstitution. This strategy of using lentiviruses and low dose of chemotherapy has now become the staple of most gene therapy protocols. And this is probably where most of our patients are going to, or this is how most of our patients are going to receive their transplant. Indeed, in ADA deficiency, this has become the standard of care. ADA deficiency, or ADA, is an important enzyme in the purine degradation and salvage pathway. It accounts for about 15 to 20% of all severe combined immune deficiencies. Inherited allelic defects in ADA are the first or second most common cause of severe combined immune deficiency. In ADA deficiency, there have been already more than 100 patients who received gene therapy, with no significant adverse effects, so much that gene therapy has now become the standard of care for all patients with ADA deficiency who don't have a matched sibling donor. It's already approved for clinical use in Europe and is being evaluated by the FDA for clinical care management in the USA. So I suspect that gene therapy is going to be the standard of care for most of our patients in the next 5 to 10 years, but we can make it even better. And one of the promising advances in gene therapy is what we call gene editing. And that is, rather than adding a new gene to the patient's cells, we actually use a technique that will allow us to correct the gene, the mutated gene in the patient's own cells. The advantage is that we're not just adding randomly a gene that can integrate anywhere throughout the genome, but we're correcting the gene itself, which means that the gene remains under the specific control, the enhancer, the promoter that are responsible in our body to control the gene itself. So this has become a very attractive possibility. There are now several clinical trials in non-PAD, primary immune deficiency, and primary immune deficiency conditions. I listed here a couple. Rather than remembering the list, just remember the concept that really CRISPR technology or gene editing is probably where most gene therapy studies, gene therapy trial studies, and clinical care is going. There's still some challenges that we need to overcome, but this is certainly the future. So, in conclusion, I want you to remember that newborn screening has changed the presentation and management of severe combined immune deficiencies. Be vigilant, because newborn screening can still miss rare cases of severe combined immune deficiency. Clearly, the earlier identification and better techniques that we can now, earlier identification of patients and the better transplant techniques that we have improved the outcome of patients with severe combined immune deficiency. For increasing number of these conditions, such as X-linked SCID and adenosine deaminase deficiency, gene therapy is becoming the preferable treatment option. And finally, I want you to appreciate that gene editing holds promise for many primary immune deficiency, and especially for severe combined immune deficiency. I do want to acknowledge the member of my division, the many national and international collaborators, and especially the patients and families with primary immune deficiency, because it's for them that we do all this work, and it's for their generosity and trust that we are able to advance the investigations and science. So I left quite a lot of time for questions. I'll be happy to answer them. I'll try and switch to a mode where I can actually see all your questions. Please, any questions or comments that any of you have?
So I'll throw out my usual question. The group's used to me always asking something here. If you had to point somebody to a single resource to try to keep up with the ever-changing innovation in the inborn errors, what would be the best resource for our learners to go to?
That's actually a tough question, because I think there's so many development on so many frontiers that's really not easy to follow. So I'll actually divide my answer into a few parts. In terms of the diagnosis, and if you're interested in advances in primary immune deficiency and the types of diagnosis, then I would recommend the International Union of Immunological Society, which publishes every 2 years an update, so the IUIS. In terms of advances in management, I would suggest to follow, and I need to confess that there is a bias because I belong to that group, but I would suggest to follow publications from the Primary Immune Deficiency Treatment Consortium. They are focused on the management of patients in North America. And so they provide what I would consider the standard of care for patients in North America with a severe combined immune deficiency. So the PIDTC, and they usually provide updates every once or twice a year, on the state-of-the-art management of patients with the profound immune deficiencies. So they're not as thorough in terms of the specific diagnosis. They don't really distinguish between most different types of immune deficiencies. They give a more holistic approach to the management of immune deficiency. And through my talk, I did mention several publications from the PIDTC, Primary Immune Deficiency Treatment Consortium. As I said, I'm biased because I'm part of that group, but I think that's probably why I'm part of that group. They do provide the most up-to-date management guidelines.
Yeah, well, thank you. And I realize that's a difficult question. There's never one single source, and there's too much always in development, which is great. But as I look at, I've got a patient, and maybe bone marrow was the standard of care, but then you could start talking about gene therapy and then next gene editing and how to know what patient and when and where, and it gets complicated. And obviously, there's some liability in the whole issue too.
So gene editing is the future. Mm-hmm. Allogeneic bone marrow transplant is still the standard of care for, I'd say, 80% of the patients. Patients with IL-2 receptor gamma who don't have a mass sibling donor, gene therapy is not yet the standard of care, but is on a research basis. And really, it boils down, the only place where the standard of care now is gene therapy is ADA deficiency. And because that is about 15% of the patients, and if you remove those who have mass sibling donors, you're left with about 5 to 7% of the patients. So still, the bread and butter and what we do with 80% of our patients, 90% of our patients, is allogeneic bone marrow transplant. But the future, 5 years from now, 10 years from now, CRISPR.
Yeah, it's exciting times.
Absolutely.
Yeah.
But what I really want to emphasize is be careful. Despite the fact that we have newborn screening, which works amazingly, there are patients that might still come up at 4 months of age, 6 months of age, even a year old, and might still have a profound T-cell deficiency. So don't be fooled. Normal newborn screening does not exclude a profound T-cell immune deficiency.
Exactly. As an analogy, we can see that with cystic fibrosis. We have great newborn screening too, but you got to set your sensitivity and specificity somewhere, so you're going to induce false positives and false negatives. So yeah, always be on alert.
And we always prefer to see the false, whatever you call false, we prefer to see the false and make sure that we're not missing a condition, right? Severe combined immunodeficiency and SPIA. These are deadly conditions, so you really want to make sure you're not missing them.
Absolutely. Right. Any questions from the audience? Okay, well, Dr. Grunebaum, we appreciate you being here once again. Fantastic talk today. I appreciate all the good information, and hopefully can look forward to seeing you again soon.
Thank you. Take care. Bye-bye.
Thanks all. Bye-bye.